Don't you, Dr. Parker?
I feel great. I was really liking that print. So I was like, I remember this song. I remember this song. And I also remember Dr. Musa. He was one of my fellows when we were all at Wesley Woods Geriatric Center. How are you, Dr. Musa?
I'm doing well. How are you, Dr. Parker? Always
Great.
good to see you, and hopefully you learn from me. I always learn from you.
Thank you. So today, folks, we're going to learn a little bit about delirium. And one of the things that's important when we are discussing people who have cognitive disorders or brain dysfunction is a lot of times the symptoms of dementia can overlap with a medical condition. And a lot of patients who are in the hospital are having acute medical issues like dehydration, infections, or even a medication intoxication. They can be delirious. The difference between dementia and delirium is something fixable. We're going to learn about that today. Let me tell you a little bit more about Dr. Musa, who is a hospitalist in the Emory healthcare system. And as you've probably gathered, I'm really excited to see him and see one of our homegrown, I like to say, graduates or fellows assisting with our outreach, but more importantly, just to know where they are in their respective careers. He is a hospitalist who started at Wesley Woods, which no longer exists the way it was when he was in training, and is now a senior hospitalist and associate professor of medicine in Emory Healthcare System. He's a senior fellow at the Society of Hospital Medicine, and he frequently delivers lectures on clinical syndromes. I'm going to say geriatric syndromes, for lack of a better term. Dr. Musa, you correct me if I'm wrong,
No.
about things that affect older patients. So without further ado, I'd like to give the stage to Dr. Musa.
Thank you, Dr. Parker. Have the slides available.
Yes, we made you a co-host for you to advance your own slides.
Um, can you see slides?
Yep, we just need it in presenter mode. We're almost there.
Where it went, but it was right there.
There we
There we
go.
go.
There we
All
go.
right.
You're good to go, Dr. Musa.
All right. Thank you very much. Well, thank you very much for this opportunity. And as Dr. Parker said, I was a geriatric fellow where she used to be my attending. That was in 2008. And since then, I've been geriatric hospitalist initially for 3 years in Wesley Wood before moving through Emory system when Wesley Wood was closed as a ACE unit. Been around different hospitals in Emory, and I've been at Emory Johns Creek Hospital, which is one of the northest hospitals in metropolitan area, and I'm as well the site director for the last 10 years. So I'm very interested in inpatient delirium as one of the most common geriatric diseases that we encounter as geriatrician. And I remember it used to be during our training that the inpatient delirium used to be the number one reason for consultation of geriatricians. So obviously, I don't have anything to disclose. The agenda, I would like to talk about the delirium in general, review some of the implication. I'm hoping I'm not going to make you a little dizzy about the literature review that talk about like the evidence on management and prevention of delirium. And hopefully we can have some summary of the take-home message and open for some Q&A. Hopefully by the end of this session, you'll be able to understand the impact of delirium on hospital stay and be familiarized with the evidence on management and prevention of delirium, in addition to compare these guidelines. So we'll start by defining delirium. DSM have defined it very well with the 4 points. DSM-5 have added 1 point, which is the additional disturbances in cognition. So I like this definition from the American Psychiatry Association, where they describe delirium as a disturbance of consciousness that is accompanied by challenge in cognition that cannot be better accounted for by an existing disease or evolving dementia. So we know that delirium increases with age. The prevalence is higher in the advanced age, above the age of 80. There's one in this small study that they done where the cohort was around 280 patients. They found that it is more common in the general floors compared to other floors. In general, we know that those patients who are above the age of 85 are the fastest growing, and they constitute around 2% of the population. However, they account for more than 8% of the hospital discharges. And the older the patients are, the more likely to have the delirium. In fact, some studies looked into different locations. In general, around 40% of hospitalized patients above the age of 65 have delirium. That number is lower in the surgical, but higher in the ICU, which is understandable. That patients are sickest in the ICU, or can be up to 80% of the patients being taken care of there. So we think about delirium as a patient is being agitated, not acting normal, but the majority of the patients look like this lady here in the picture. So they are usually dazing, and this is the hypoactive delirium, and we'll talk about the different types. So the patient look like withdrawn, different than previous days. This is what how the patient looks, but this is what the patient actually sees. She sees the environment distorted around her. When a patient called the nurse and tell her that I've seen a man in my room, or I've seen a rat, or I've seen whatever they do see, they actually see that. And that's very scary and can make a person unable to rest and get agitated. Some of them, they feel scared. They try to walk, and if they are unable to put their feet down, they may fall, fracture something. The incidence of delirium, one of the German studies that I'm showing here in this slide, looked into, obviously we know that the delirium is more pronounced in the afternoon or in the evening. So this study shows like up to 22% of the patients, they do have delirium even in the morning. That obviously increased to 30% in the late afternoon, sorry, and the majority of them are, around almost 50% at the late shift. And they looked on the patients to see when actually they develop delirium, and it's usually the third day. If the patient is delirious on admission, probably because of having certain stressor, whether that pain, infection, other things, and by receiving some antibiotics and things like that, they improve initially before they get higher and get worse. The same applies to patients who are abusing certain drugs, whether alcohol or other things. They usually withdraw after 48 hours from being in the hospital and withdrawing from these medications or material. The features to qualify for the delirium, you have to have 3 of these 4 features. Obviously, there has to be some altered mental status or fluctuating course of that. The patient needs to be having some inattention and the disorganized thinking. So the BCAM, which is the looking into the how they can look into checking on the who has the delirium or not, is not very sensitive, but could be specific, especially in elderly patients. Now, it's under-recognized in the hospital. So up to 28% of the physician only recognize delirium, because the patient condition fluctuates during the day, and physician probably will see them once a day or maximum twice a day if they want to follow up on certain labs or tests that came back. The nurses are more likely to recognize them, but even nurses who are staying in the room in and out all day, checking on patients, taking vital signs, they still recognize delirium only in 35%, and that red number is the difference between physician and RNs. And the majority of them, they are under-recognized. So patient can be under-recognized, especially if they are hypoactive. Like today, the patient did not really want to eat. Today, the patient looked like more sleepy this morning or something like that. The odd ratio of having the patient to have high risk for delirium, usually it's almost double if a patient has vision or dementia, and can be up to 7.7 on certain conditions. So delirium types, we understood that it is can be the excited delirium, which can be from agitated to combative, easily to be noticeable. The patient, all the nurses know about this patient. And the catatonic type, which is mostly hypoactive, and these patients look like depressed, cognitively impaired, confused as a simple term. And the majority of the patient, they usually fluctuate between these two forms to develop the mixed type of delirium. The risk for delirium can be either premorbid, which means like based on their health records, if the patient already have dementia, advanced age, if they already abuse some drugs or alcohol, if they have any visual impairment, or they are depressed or having a previous history of delirium, obviously they have a high risk of developing delirium in a hospital. Then after that, looking into the factors related to the presenting illness, if the patient has an infection, dehydration, electrolyte imbalance, acute kidney injury, obviously they are more likely to have that. Not to mention the surgery, if patient go under the knife, anesthesia exposure, these are by itself risk for delirium. And the post-admission, so after being admitted, how the infection is developing, if the patient developed ileus after surgery, if they're having more pain, not well controlled, sometimes just giving pain medication. So if the patient has pain, have more delirium. But if they get a lot of opioids, they develop more delirium. So it has to be in the middle between making sure the pain is controlled. Hopefully, we are avoiding opioids while trying to make sure that the patient has good control of their pain. Polypharmacy, just some of the patients, they come to the hospital with a huge list of medication. Some of them probably can be cut or removed. The other things would be like if the patient has been in a hospital for a longer time, ventilated for a longer time, been exposed to these restraint, or having some other bad outcomes. And one study that was published in the Mayo Clinic proceeding, they looked into these characteristics here that you see on this side, and whether the patient is surgical or medical. And you can see here dementia by itself can be almost double risk when it comes to be in the medical, but can be up to 3.5 times if the patient is on the surgical level. And the others, as you see it here, that could be as simple as having a fib more pronounced in the surgical floor. There is a fracture more on the floor, more on the surgical. If the patient has anemia, can be as well risk factors. So the implication, why are we talking about this? The delirium has multiple outcomes. Obviously, luckily, the majority of them have full recovery. But some of them, they still have issues, and they have to be develop some functional and psychological impairment. Some of that needs to be taken care of either by sending the patient to a rehab center, sending them to psychiatric units. When a person develops delirium, they usually have to stay longer in the hospital to be taken care of. And rarely the delirium can lead to death. The boost is one of the better outcomes of optimizing safe transition project that was done by the Society of Hospital Medicine, trying to identify patients who could be developing delirium in the hospital and working on how they can work with them on discharge and after discharge. It was a study that was published in 2013 and looked into how to minimize the risk and getting the patient as well as family members on board from the beginning. Another study by the Society of Hospital Medicine in 2021 looked into a big cohort of 22,000 of those patients who developed delirium in the hospital, and they tried to do certain adjustment to see if that will be translated into some better outcomes. And those patients who have been followed up, and that was in 2018, I believe, the study was done, and published 2021, looked into that and found that the length of stay for all the units were minimal, but 2%. The adjusted cost benefit was around 7%. And for all units adjusted when it comes to readmission, because a lot of these patients, they are discharged, a little confused. You would expect when they go home to get better, but for some reason they don't. They get some more issues. They can be falling, having aspiration, other things, and they have a high risk of readmission. So for that study that they did when they implemented the multi-component pathways, they reduced that readmission in 14%. And that's usually translated in a lot of money. Nurses already have their own protocol when it comes to making sure that the patient is well taken care of, and to try to reduce the delirium. They look into what the patient needs are and try to anticipate it and work with them, promoting hydration and orientation, mobility, as makes sense. And obviously part of that, talking to the family and make sure they are aware about what's going on. Because a lot of family comes and they say, "Oh, what's happened to my loved one? They were fine yesterday. You did something for them." We need to. It takes education about what's going on, and we need some support from the family, because they can tell us, "My loved one is not acting normal. I think the patient is developing delirium." So we can get some of these clues because family knows the patient the best. So the confusion assessment method include these four components in addition to disturbance in cognition. As just shown here, high sensitivity, but sensitivity specificity is not that bad. And it's usually used mostly in the ICU as well as the floor. There is the Society of House Medicine have developed the ultra brief bedside exam, lower sensitivity and specificity, but it's easy to be done. Instead of getting a paper and trying to fill the CAM, you just ask two questions. What is the day of the week? And can you take me from this month backward in the month? If the patient has difficulty to do that, usually they are delirious, but they might be able to do it and still they are delirious. But that's why the specificity is around 70%. We don't do much neuroimaging for the patient with delirium. Because it's costly and that does not really show a lot of acuity. But however, there are some cases that we need to do CT, especially if there is a focal neurological deficit associated with the confusion, as a stroke usually present like this way. So I'm gonna spend now this part of this discussion about like the literature review on prevention first, and then on management. We'll start by looking into the prevention from the non-pharmacological measures. This is a study published by the Cochrane Library and looked into the intervention for preventing delirium. They found that there is improvement in delirium incidence, length of stay, but not changes in mortality. The data reviewed were including making sure the patient has good mobility, looking into pain control without specific opioids, make sure the patient is well hydrated, oxygenated, improve bowel regimen. We have some patients who just come to the hospital delirious, and what they have is basically obstipation or constipation. Sleep hygiene is kind of relatively difficult in the hospital because they keep checking vitals and labs and things like that. We do have a condition where we put patients not to be bothered between 11 p.m. till 6 a.m. and to do the labs later on. And that definitely has helped a patient from developing delirium. The National Institute of Health and Care Excellence, in addition to the American Geriatric Society, looked into all these guidelines, and they are in favor of, both of them are in favor of the non-pharmacological prevention of delirium. The pharmacological agent that can be used for the prevention can be looking into the sleep, which is including melatonin, the cortisol level, which is usually affected by benzodiazepine, the anticholinergic effect from the cholinesterase inhibitors, and the dopaminergic transmission from the antipsychotics. And we'll spend more time on the antipsychotic. So this is the study on melatonin, obviously in favor of melatonin compared to non-melatonin when it comes to preventing delirium while taking medication, but it's not statistically significant. In order not to go through all this detail, this is a slide summarizing what's going on. So basically, recommendation is to not to recommend antipsychotic or cholinesterase inhibitors for the prevention of delirium in the hospital. So the NICE and AGS looked onto these three categories, and there is no specific evidence that they help. Definitely, there is a strong evidence against using cholinesterase, especially from the AGS. When it comes the take home here from the prevention part is that we should use non-pharmacologic measures, maybe some benefit from antipsychotic and melatonin when it comes to prevention, but definitely no benefit. In fact, there is harm from using cholinesterase inhibitors in the hospital while trying to prevent delirium. So let's try now talk about the treatment of if a patient already have delirium and what we can be doing. So same approach for that. We'll take it from here. So medication to avoid when treating delirium is cholinesterase inhibitors and benzodiazepine. And this is here a long list of the research that supported that. Definitely there's a safety issues, and including the QT prolongation and other side effect, or some of these patients can have bad outcomes without much benefit. The antipsychotics started to be utilized since 1950s. Haloperidol was the first one, and currently haloperidol is one of these medication. In fact, all antipsychotics are the one of the things that we do for no reason, especially for delirium treatment, and I will show you the evidence about that. So we start with the AGS, and that's looking into the antipsychotic medication for prevention and treatment. It was a big studies, as you see here, 19 randomized control studies, more than 3,000 ICU and floor patients, and they looked into the usage of antipsychotics versus placebo. When it comes to the outcomes, they found that no benefit on mortality, duration, severity, or length of stay. Maybe a patient who did take some of these antipsychotic had less discharge to subacute rehab for a longer time. The Cochrane looked into as well patients for the treatment by antipsychotic, multiple randomized control study, quasi-randomized, around 700 patients, the smaller number, and they looked into placebo versus the antipsychotic medication. And the outcomes was as well the same thing. The only difference was when it comes to duration and length of stay, these patients did not have any other benefits. The Annals of Internal Medicine had the 26 randomized control studies, 9,400 patients, atypical antipsychotic versus placebo. And as you would expect, majority did not favor. There was some benefit in the annals on the severity of the patients, and questionable when it comes to the benefit and risk from the neurological side effect or cardiology side effect. So putting that compiled together, antipsychotic for the treatment, there is no benefit on duration, severity, length of stay, mortality, resolution, or sedation. What usually the risk? There is more problem with the antipsychotic when it comes to the cardiac rhythm, with the QT prolongation, and neurological symptoms like extrapyramidal symptoms, the anticholinergic symptoms, and other things. So criticism of these studies that we showed now, we definitely need more studies in order to be sure that since there are some mild discrepancy between the different studies, we need to have different antipsychotics and different dosage. Some of these patients have been on a high dose of antipsychotic, which we usually don't use in the clinical scenarios. They concentrate more on the hyperactive patients compared to hypoactive. And the population used was kind of skewed, did not reflect all the races involved. And patient safety was not described well on these studies. So the guidelines from the antipsychotics for treatment of delirium, they recommend not to use antipsychotic and can be used only in extreme cases. The patient is agitated, about to hurt themselves or others, you can use that. The same thing applies to the American Geriatric Society. So summary of the evidence-based management in general. When it comes to treatment, the patient, there is no benefit of benzodiazepine, antipsychotic, routinely used. However, you can use them in when it comes to patient safety, extreme agitation. When it comes to prevention, only non-pharmacological measures. Do not use the medication, even if it is melatonin or other simple medication that can be available over, everywhere. The safety, as we need to make sure that everybody remember that the major antipsychotic safety issues is usually NMS. When it comes to the arrhythmia, could be QT, prolongation, torsade, and definitely all of them have anticholinergic effect. Special population, Risperdal and olanzapine can exacerbate Parkinson. We usually prefer Seroquel and clozapine on these patients. And there is the TADA kind of like approach for the management. Always they talk about tolerate the patient, allow them to respond to their circumstances, support them, anticipate what's going on. If there is some going to be more pain, more other issues, discontinue unnecessary attachment, and do not agitate these patients. You know, when a patient is like confused, agitated, you know, we need to de-escalate and try to avoid anything that can make them uncomfortable. These two studies that you see on the right side here, they looked into the benefit of early mobilization on the patient delirium when it comes to, in general, being in the hospital, and specifically if we can move them earlier during the day compared to the others. And this, I will call it, is the bulb that enlighten and summarize the real benefit of taking care of these patients. So obviously, we need to start by making sure there is if there is infection, spotted and treated. Pain, if there is a patient, pain is controlled, they will be less likely to be having the delirium, but don't use opioids if possible. The easier things what can make sense is to make sure the patient has a good diet, hydration. They say don't get delirious, sleep is serious. So it's easier said than done, because in the hospital, it's really hard to keep the patient sleeping well, because first of all, they are in a new environment. They're probably not in their best condition medically. And some people, they have their own special bed and they cannot sleep well. Nurses can be noisy, many reasons for a patient to have problems sleeping. The environment is just like be house proud, help the patient, orient them, use all the tools that you have, engage them and use the sensory aids, and always be kind to these patients and be mindful of their emotional needs, and do not prescribe delirium. The worst thing is like a nurse calling you, just like, this patient is delirious. I want you to give me some medication. I cannot take it anymore. Just like we need to work together on making sure to avoid just give a medication for every symptoms the patient have. So as a take-home message here, we should encourage non-pharmacological measures to prevent delirium, use ultra-brief bedside or CAM to identify the delirium. Remember, most of the time we miss the diagnosis and we underdiagnosed it. And if we don't know about it, we cannot treat it. Rule out other reason for encephalopathy and agitation, because not everything is delirium. Sometimes patient can develop meningitis, encephalitis, and other things. Correct medical illness and adjust medication. Sometimes all it takes is just making sure, you know, hold some certain medication, especially those that can be toxic, especially in the context of dehydration. Avoid benzodiazepine, avoid antipsychotic if possible. And if we have to use them, then just start low, go slow on the dose and see how they do. I hope that I did not make you delirious. I know that we had some limited time. That's why I had to go through these slides quickly, but I'll be more than happy to entertain questions if you have any clarification. And thank you for your attention.
Thank you, Dr. Moussa. There was one question, and I kind of answered it in text and Q&A, but would you please talk about elevated sugars? The question was about sugar. So can elevated sugar cause delirium? And for diabetes patients who are in the hospital, high sugar, low sugars, they can be just as bad. Can you explain to the audience what that means, please?
Definitely, yes. Thank you for the question. Yes, so definitely, if the sugar are in the extremes, definitely they can cause a problem. So it's that, in fact, not just high glucose level, hypoglycemia, low blood sugar is well known to make people like more sleepy, and that's probably related to the fluctuation of the electrolytes. Another things that can develop and can cause the patient to be having delirium or confusion is usually the electrolytes. So a simple one would be the sodium. The older we get, we have problem concentrating the sodium in the blood. We are less likely to be able to drink water. and there is a problem with the reabsorption of sodium in the kidneys. So hyponatremia is very common. As we know, when it comes to the hyperglycemia and diabetes, there is if the blood sugar is very high, talking about like more than 200, 250, there's a component of lactic acidosis. Obviously, in the extremes, develop diabetic ketoacidosis, as everybody knows about it. So that can lead to a patient feel weak, confused, and having problem. And by itself is considered to be a medical stress and definitely can precipitate delirium.
On that note, though, aside from diabetic abnormalities, when you're in the hospital, I imagine you're seeing quite a few patients with a lot of things. You talked about sleep deprivation as a reason for having problems with delirium. What about infections and delirium, and what kinds of infections?
Yes, that's a good question as well. So definitely all infection can cause delirium, but the typical one for a geriatrician is usually looking for the deep organ, whether that is like UTI, colitis, pneumonia, not to mention like the infection of the brain, sinuses, other dental infection. I had a patient who came recently and the major reason for their dementia, the delirium was dental surgery recently, even though they've been on
Dental
antibiotics.
surgery.
Yeah. So they just like the patient was like in mid-70s and supposed to be doing well and had the dental infection and scan all these kind of things with the proper antibiotics. They got better. So amoxicillin probably not the best medication for the mouth, but that's what usually mostly used. Clindamycin in an IV format can help patients better. UTI, the geriatrician obviously are always tailored to look into this. Not every cloudy urine is infected, obviously, but there is some patients who do develop pyuria, which is infection in the urine and can be just real infection compared to just being chronic colonizers. Where I have patients, I'm just having a patient right now in the hospital here for delirium and confusion, and she had a lot of stool despite having loose BM, and she has been taking Imodium for the last 2 weeks. Obviously, that is overflow diarrhea, and the CT showed a lot of stool all over. Just saying that there is no way I can be having constipation. I'm having diarrhea, and I'm using Imodium, and it seems like the Imodium is keeping the stool in, and obviously coming as pain in the belly and leading to confusion.
Hmm. Hmm. So we've talked about infections like urinary tract infections. We've talked about diabetes. You mentioned in your talk medications, pain medicines. Can you explain how that can make people confused? Because people think, just like that, I loved your explanation of chronic constipation creating a problem, but what about medications and older people taking medicines they're supposed to take?
Yeah, well, that's what I mean by the proper dosage and the adjustment of that. So polypharmacy is like when patients take multiple medication, and there are some medication that interact with each other. Some patients they like to take a pill for every symptoms. So they will find that they have like 20 medication on their list when they come to the hospital and trying to decipher which one is really important and which one we want to continue or stop. When it comes to the pain medication, some of them, they tell you, I've been taking this oxycodone for 10 years. But guess what? Now you are dehydrated and your creatinine is like 3. And before, when you were using it, you were normal creatinine. And now it's becoming toxic in your body. And when you start talking to the patient and make them understand that the level of the distribution of the medication, when it comes to, especially those who are lipophilic medication, that they can penetrate the brain, in the context of dehydration or other medication, it's very common and probably more in the outpatient level where patients develop higher blood pressure and they start them on diuretics and they are dehydrated and with the diuretics and they are still on the same medication, but now they become toxic in their body. So when we get fluid, we hold some of these medication, they can get better. I have a patient, in fact, still in the hospital, is on triliptal for trigeminal neuralgia. And she taken like a 450 milligram TID. She came here with a level more than 45, and it's toxic above the age of above 40. She claimed that that's the only medication can make her pain get better. So that you have to make this discussion about, like, yes, you are not on opioids, you are on, other meds that can help with the pain, but we have to be attentive to the toxic level and adjust medication. Maybe use 2 medications instead of only triliptal, added some Lyrica, lower dose, and, working with these patients on not to keep increasing the dose every time the symptoms get worse till they reach a level of being toxic in the body. Because when this reach that level, as you know, triliptal takes like 3 days for the level to come back. And by the time we suspect it in the hospital and we try to lower it, patient, feel in pain, and we're trying to give them some other ways. One of the things that some other patient may have a problem with is that, taking a lot of NSAIDs as an outpatient, because it's easy, you don't need prescription, you can take it.
Tell them what an NSAID is. I'm sorry.
Yeah. Oh, sorry. Yes. So NSAID is the medication, like steroidal anti-inflammatory medications, similar to ibuprofen, Aleve, things like that. So when patient is having pain, they don't have access to get strong pain medication. They use whatever is available. Aleve, ibuprofen is the easiest one, and they start taking like 3 tablets 5 times a day or so because the pain is pretty bad. And after a week of that, out of a sudden, there is a GI bleeding, patients are vomiting blood, black stool, feeling dizzy, and other things will be leading to kidney problems. So some of these symptoms can get better, especially on the kidney if you stop early, but some of them could be permanent damage that can develop from these medications. So what I'm trying to say is that when a person comes to the hospital with pain, we always look to see what the patient are using. They'll be surprised about the supplement people use all the time, that make sure that you keep that in mind when it comes to what they actually believe that they are using for what reason. A simple thing will be like turmeric or other things that you can use, and sometimes it can be toxic in high dose if utilized.
Okay. I'm not seeing any. Okay, Q&A 4. All right. What about the use? This is a good one because this one does cause a certain amount of craziness. Risperdal for an Alzheimer's patient. Does this cause delirium? This is one of my favorite questions.
Well, it is the antipsychotic, right? So we were talking about the studies that showing antipsychotics. First of all, they do not prevent delirium. And if the patient already have delirium and you want to treat delirium, you need to be careful with the dosage and how how the patient do. Yeah, Risperdal is one of the medication that we can use. In fact, it's favored but more by psychiatry than by neurology or geriatricians. But the idea is that it's one of the antipsychotics that you need to keep in mind the development of NMS, anticholinergic effect. So anticholinergic effect, who don't know what is it when it comes to medication utilized for dementia, like Aricept, Namenda, all these medication, anticholinergic meds, they do dry the mouth and make the bladder unable to empty the bladder. So patient come to the hospital with the creatinine elevated because the bladder has 900 cc, and we put a Foley catheter to help. And the treatment of that is just to get off this medication, compared to others that they can get over the counter, which is like antihistaminic medication, other medication with the anticholinergic effect. So, I mean, multiple things can be looked into. Risperdal is a good medication when used for a specific condition. Patient in the hospital develop delirium, and we try to rule out other causes or risk for the delirium. And if still not did not find any, or we are working on the improving the symptoms. If the patient is a risk for themselves to hurt themselves by pulling IVs and run in the middle of the night, and they are having problem with their hip and they just kind of fracture their hip, then we got to do something. It's one of the chemical restraint compared to the physical restraint that sometimes we have to use, even though it's almost very rarely utilized except in severe cases. So yes, Risperdal can be one of the medication. Seroquel is another medication used for a shorter duration. We try to avoid the typical, we call it antipsychotic, like haloperidol. However, if the patient is agitated, I will not take the pill. You give them pill, they spit it up, and they shouting. We had a patient one time who was choking choking a nurse. So we had to do what we had to do, and we had to give them, more like Geodon, IM, or something like that, in order to calm them down, let them rest, and try to figure out why you are delirious, understanding this is a medical problem with some mental component to it, and try to, rule out other reasons.
So another question, thank you, Dr. Moussa, for that explanation. There's a question that says, how quickly is a person expected to clear from delirium with appropriate treatment? It's not instantaneous, folks, but.
Right. Well, depending on their condition. If you remember that slide that I showed, like usually it start to increase after day 3, delirium, and subside after day 5 to 6. There are some patients continue to have some delirium even after discharge. Some of them, they can stay here for like, a week or 2 in the hospital. Most of the time, patients get a little better when they go back to their environment. They can eat whenever they want. They have their own room, their own pillow. Whatever they do at home, they usually calm down their confusion. However, some of them, they continue. And in fact, one of the studies looks into, if a patient developed delirium, what's the likelihood to develop actual dementia that was not actually diagnosed is very high. So there are some patients who continue to have delirium up to like 3 months, not as intensive as what they were in the hospital, but can continue to say, well, since my loved one was in the hospital sick for any reason, till now they are not back to normal. It can be taken multiple months, and some of that delirium can unmask the undiagnosed MCI or dementia or other type of the cognitive impairment.
Okay, and the last question here, and this looks like the last one for today. Can you tell us what catatonic delirium is? Now, delirium is a fluctuating state. Somebody wanted to say what the definition of delirium was. It's a fluctuating state of consciousness, usually precipitated by a medical illness, and it is reversible, but the longer it stays around, the more likely it is to be more of a permanent thing. What is catatonic delirium? You talked about hypoactive delirium with the lady who was laying in the bed. That's the example you showed. What's a catatonic delirium? I didn't realize there were so many differences.
Well, it's describing the patient, how they look like more withdrawn. So as you said, it's easy to notice a person who's agitated, who's biting, who's shouting, who's screaming, but those who are just telling the family, tell you that my loved one doesn't want to eat in the hospital, doesn't want to talk to anybody, who just want to sleep all the time. They are withdrawn. You try to get the physical therapy on board. They don't want to move with it. It's that kind of type of like severe disinhibition. Not in disinhibition. It's like more, they look like inhibited in their will or energy, and that's what catatonia mean in this condition.
Okay, I think that's it. So thank you so much, Dr. Moussa. You're free to go back to your patients in the hospital. Thank you for taking this hour with us. We do appreciate it. And you will be hearing from Marissa within the next week. This particular presentation for our audience will be uploaded within the next week, probably by Monday on our YouTube channel, so you can come back and refer to it again. There were some questions earlier about, can I see this a little earlier? All of our presentations on BrainTalk Live are in our YouTube archive, YouTube TV. Just look up Emory Alzheimer's Disease Research Center and go to BrainTalk Live, and we have all the things that we've done on our YouTube channel.
Thank you very much for the opportunity to talk to you today, and I'm hoping that I was able to give you some information that maybe could be a little technical when it comes to showing these studies, but the idea behind it is to show you that there is a lot of work been done behind this to come to these conclusions that we are discussing today.
Well, thank you. You gave us a lot of information because you generated some really important questions. So this was good.
Awesome.
Thank you.
Thank you.
Emily?
Yes, thank you so much. Hey, one quick question. Is heat related? Can delirium be aggravated by the heat if they're dehydrated?
Oh, that's important.
That's a
Yeah,
good question
definitely,
with the heat.
especially
Yeah.
nowadays, like last couple of days. Yeah. So basically, dehydration is one of precipitant of the delirium. With this being always the weathermen always talk about, like, you have to be drinking a lot of water because that can make you confused. The heat exhaustion problem, the heat stroke are part of delirium if you think about it. Just like the body is unable to get the conserved heat inside the body. And yeah, stay hydrated, everybody, and drink a lot of water, as was said initially.